Good evening, everyone. We will be presenting a complex case of hangman fracture who presented to us around 1 year after injury, and he was a poor patient. So we have to arrange the money and all things. Then we did the surgery. So Dr. Ravi will be presenting the history of the patient.
So this patient was a 32-year-old male presenting to us with a history of road traffic accident 1 year back. He was a pedestrian hit by a four-wheeler. At the time of the accident, the patient was treated for a right TMJ dislocation with blunt chest trauma and a left-sided both bone leg fracture. However, there was not much attention which was given to a history of dull aching neck pain, restriction of neck movements. So this was a case of a missed cervical spine injury and also the injury of the CVJ, which was not evaluated at that time. Months later, patient started developing symptoms of mild weakness in the remaining three limbs with paresthesia and numbness below the neck. Patient presented to us 1 year after the accident, and at the time of presentation, patient was Asia grade D with a power of 4/5 on MRC scale, with evidence of spasticity and exaggerated reflexes and bilateral upgoing plantar. Patient also had a graded sensory loss to all modalities before cesarean. Now I would like to invite Dr. Vinay for radiological evaluation.
Good afternoon to all. I'll be in brief describing the radiological evaluation of this patient. So this is a sagittal view of the cervical spine in which we can see there is complete dislocation of the C2 vertebra, and it is lying completely anterior to the C3 and the C4 vertebra. So this is known. This is called as a spondyloptosis of the C2 over the C3 vertebra. This is nothing but the grade 5 spondylolisthesis of the vertebra, in which there is complete subluxation of a superior vertebra over the inferior vertebra. Now, in this sagittal scan, we can see there was also absence of the pedicles of the C2 vertebra, both on the left and the right side. On the coronal section, we can see there is dislocation, right lateral dislocation of the C2 vertebra. And this is the axial section of the cervical spine at the level of craniovertebral junction, in which we can see this is the dense process and this is the arch of the atlas. And we can see there is widening of the neural arch. And again, this is at the level of the C2 vertebral body. So the C2 vertebral body is completely lying anterior to the C3 vertebral body. And there is also narrowing, retroluxation of the C3 and C4 vertebra, which was causing compression of the bony spinal canal. This was a CT angiography which was done, and which we can see the vertebral artery was normal and it was dominant on the left side as compared to the right side. And MR was done outside AIIMS, in which we can see there is retroluxation of the fractured C3 vertebra, which is causing severe compression of the spinal cord, and there is also evidence of the T2 flare hyperintensity within the cord. So now I will invite Dr. Samira to describe the pre-anesthetic checkup of this patient.
Good afternoon, everyone. Our first contact with the patient was when we visited him for pre-anesthetic checkup. So he was a young patient, 32-year-old, who was ambulating, not bedridden, and the history of road traffic accident was more than 1 year ago. So all the trauma related to the RTA was probably completely healed, and mandibular fractures were also fixed. No comorbid illnesses were there, no respiratory distress at presentation. Patient was able to protect his own airway, and the patient had no history of allergies. On clinical examination, we found that the power was at least 4/5 in the upper limbs, and his cough was intact. And airway examination revealed that mouth opening is adequate, but the patient was on cervical traction, so neck movements were severely restricted, which poses difficulty for our airway management, especially laryngoscopy. And biochemical radiological investigations were normal, chest x-ray was normal, and we have started patient on incentive spirometry in the preoperative period itself. So in this patient, our main concern is because of difficult airway, which preoperatively is because of unstable cervical spine, and once the surgery proceeds, after surgery, the difficulty will be due to fixed cervical spine and no movements will be allowed at that time also. So the other concerns were difficult weaning, prolonged postoperative course, infectious complications that are expected in the post-op period, and associated autonomic dysfunction. So to tackle the difficult airway, There are two things that we paid attention to. One is adequate preparation in terms of equipment, drugs, extra personnel required, and the plan in case of failure to secure airway. And the technique, awake fiber optic bronchoscopy is considered to be gold standard in this scenario. However, with the advent of video laryngoscopy along with mills given appropriately, it has a lesser learning curve, and it is considered to be non-inferior to intubation in terms of cervical movement. So how did we proceed in this patient? So after stocking up and checking the difficult airway card, we pre-oxygenated the patient adequately, and one operator standing by the side of the patient facing the intubating person, he has given steady pressure on the occiput of the patient in order to counteract any movement that might occur during video laryngoscopy. So intubation was carried out with the help of a stillet. And intraoperative concerns for us in this patient were that along with maintaining stable hemodynamics, we paid careful attention during transport and positioning of the patient. We might need to turn the patient prone and back supine, and during these moments we are not allowed to, we are required to maintain the cervical spine in neutral position. And if neuromonitoring was required, we would have altered the anesthetic technique, but it was not done in this patient. So I request Dr. Pankaj to take over for operative intervention.
So this was a very difficult case, and first time we have seen such a dislocation going up this C2 going up to C4, and a relatively intact patient, that is 4/5. So it was a difficult situation. So what came in our mind, how to proceed? We should put traction, do anterior, posterior, or combined. So, but obvious was that we have to go for traction initially. So we have put him on traction for 2 weeks. So you can see this body has C2 body has come up to C3 lower part. Initially in the CT it was the upper part of the C4. So there is slight reduction. Initially we were thinking that it is fused, but after traction so after so after traction there is a slight reduction. Initially we were thinking that it is fixed, so we were planning to do drilling anteriorly, but luckily there was a reduction, so that part was left. So this was the reduction after putting him on traction for 2 weeks. Then so again we decided, this time we decided that we should go for anterior release. So this was the first surgery. We did anterior release and put him on traction. So there is a slight reduction, slight more reduction. Then again we went in, that is the second surgery. We did the anterior release, and on the same sitting we made the patient prone and did posterior release also and put him on traction. So this time we have got up to upper border of the C3. Okay. So this is after 2 surgeries and around more than 1 month, around 1 month of traction. So after that, there was dilemma to go anterior, posterior, but we decided to go posterior because we have gained the experience of one case just before this, putting direct C2 body screw. That is the first time in world literature. That was also an old case in which C2 pedicle was reabsorbed. So with first time in the world literature, we have put direct body screws and pulled it back. So we decided to go by that experience. Okay. So we put a C4 pedicle in this. OARM helped a lot because putting pedicle screws in cervical spine is very difficult. So we put C4 pedicle to gain pull out strength, C3 lateral mass, and to prevent motion of C2, we have put a rod and hooked it under the C1 arch anteriorly, so that there is no movement of the C2 body during O-arm scanning and this putting C2 body screw during navigation. Okay, otherwise it will be a mobile segment. So innovatively we have put this is the C1 arch posterior part. We have put a rod anterior to it so that it doesn't go anteriorly. Okay, so we have, after putting the C2 body screw one side, we have put the rod screw construct. So now the C2 body is fixed, it will not move. So same we have done on the opposite side and put both side this C2 body screws with bicortical purchase to have a good pull out strength. We have gone beyond the anterior margin of the C2 cortex. Okay, this is C3 lateral, this is C4 pedicle screw, and we have put then both rods, and you can see almost complete reduction in the same. This is the third surgery. Okay, and immediately we turned the patient anteriorly, and we put a bone graft and did anterior cervical plating. So, and the technique I will just describe how we do the pedicle reformation. This is you can see the lateral subluxation also resolved. It has come almost in this straight line, and there is the pedicle formation also there. Okay, and you can see the bicortical purchase. The screws are going beyond the cortex on both sides. In pedicle reconstruction, what we do is we drill the this part of the screw of the posterior part of the C2 body, so it becomes raw, and this is the lateral mass of the, this is facet of the C2. So here also we do drilling and put bone chips around this screw, both sides screws, so that bone forms around it from C2 body to this lateral mass and facets, and pedicle is reconstructed. This is how, this is the diagrammatic. Dr. Shashwat made it for me. So this was it is up to C4 initially, and this is lateral. Okay, after traction, this much. After traction and release, anterior release, it has gone slightly up. Again, anterior release, posterior release, it has come up to upper body. Okay, and this is the procedure. We put direct body screws, 3 lateral, 4 pedicle, and this is the reformation technique. You put bone graft. This is the gap. Okay, so you put bone grafts. This is the facet, and these are the bone chips you put. So it forms the pedicle. Now I will call anesthesia colleague to. The post-op course was very stormy, so I will.
So the first question that we faced after the end of the third procedure that the patient undergone was whether to extubate the patient or to continue ventilation into the postoperative period. So the patient, especially this patient who has undergone 3 surgeries and had been intubated for a period of 8 to 9 days before the last procedure. So there are chances of airway edema, impaired oxygenation if the patient has already developed VAP, and any neurological deterioration or impairment in cough that can occur at the end of procedure will also have bearing. So we also had a plan in case of during elective ventilation, if the patient accidentally loses the airway, because of fixed cervical spine, we had laryngeal mask airways backup beside bedside all along. So in our patient, we shifted the patient down tube into the ICU, and we started weaning from the first postoperative day, as the patient's power was similar to the preoperative period and the cough was intact. On the second postoperative day, we observed that he developed tachypnea and we were not able to wean him any further. So the X-ray was showing a blunted CP angle on the right side mainly. This could have been effusion, and thin mnemonic effusions, especially in these kinds of patients on prolonged postoperative ventilation, are expected. So we treated the patient with appropriate antibiotics, nutritional support, and aggressive chest physiotherapy. So gradually we weaned, gave TP's trials, and once we were convinced that the patient can be extubated, because keeping in mind the difficult airway scenario, we extubated the patient over an airway exchange catheter, as you can see here. The airway exchange catheter was left in place and oxygen insufflation was continued in the post-operative period for some more time until we were confident that the patient will be able to manage his airway without it. So this, in case of airway failure, this would have served as a conduit so that we could secure the airway in an emergency scenario. So after extubation, we started the patient on incentive spirometry, and this was the post-operative X-ray after extubation. X-ray after extubation. Some amount of effusion still persisted, and this should not be considered as contraindication for extubation as long as the patient is clinically fine and doing well. So I request Dr. Pankaj to continue.
This patient was operated around 27 months back. This is a follow-up X-ray. You can see the advantage of this procedure is that you don't include C1 in this. So a lot of rotatory movement is preserved. So the main aim of surgery is to preserve functionality as much as you can. So you can see the rotation, the patient is doing good amount of rotation with flexion extension. We try to avoid including C1 or occiput. You can see this is 12-month solid fusion. Pedicle reforming. You can see the lateral displacement is also corrected and there is solid fusion. And this side also there is pedicle formation. So these have been described in literature, but recently we have, due to our experience in hangman fracture and due to latest gadgets, especially the O-arm, we are able to do these kind of cases. One for this cervical tumors, they have described, they have done one side, they fixed the lateral masses on one side, from which side they were not going, and they have drilled the opposite side C2 pedicles of the cervical spine to reach the tumor, but they haven't, they have not reconstructed the pedicles, they have fixed the opposite side, plus 2 levels upper and 2 levels below. So this we have published in JNS, and this is the first time in world literature that C2 pedicle reformation technique has been described. And yesterday also one of our paper has got accepted. It will come in World Neurosurgery. So main thing I have already told, the preservation of neck motion, and it is not very difficult if you gradually increase your skills. It is the main thing is you have to avoid the neural structures, especially the CT angio is helpful. We dissect the vertebral arteries laterally and C2 root, and when you reach the body, it is very easy to put whatever size you want. You can put, because the pedicles are not there. You can put whatever size, 3.5 and 4. There are 2 screws, so you can put 4 mm screws directly into the body with bicortical punches and good pull out strength. Thank you. Any questions? No, Pujo?
So what is the if both are fixed, there is no reduction in
Initially, we thought that it was fixed. We were planning to go anteriorly and drill the fuse part. Go anteriorly and disengage, then put on traction. But luckily, there was some reduction on traction. So that one procedure we avoided. If it is fused, you have to disengage. Then you can leave. Okay, I think there are no questions, so we can.
explain very nicely. Thank you very much, sir.